Good evening, everybody. I am Dr. Satyam Chakraborty, and I am a consultant endocrinologist at Fortis Hospital, Kolkata. I have around 5 to 6 years of core endocrine practice to my experience with around 16 peer-reviewed publications. So we are here to discuss about this wonderful combination of empagliflozin and linagliptin, and where basically there always remains a query about where we should put this wonderful agent to extract the maximum benefit out of this. So I will discuss a case vignette which will help us to understand where we can use this combination and get the maximum possible results. Often what we have, that we often have patients who are diabetic for a long duration on metformin full dose with a high dose of sulfonylurea, along with lifestyle modifications and normal renal functions within a milieu of cardiovascular disease. Now, when this type of patients, which often we get, they present with you, they may be in three scenarios. The first scenario, the patient is already on an SGLT2 inhibitor and the HbA1c is 10. Now, same patient, if with an HbA1c of 8.5 and already on a DPP4 inhibitor. And again, the third scenario, the patient is having HbA1c of 12. So in these three cases, so again, let me reiterate. First case, all the cases are long duration diabetic with full dose of sulfonylurea metformin. In the first case, HbA1c 10, patient is already on an SGLT2 inhibitor. The second case, HbA1c of 8.5, patient is already on a DPP4 inhibitor. And in the third case, patient is having an HbA1c of 12. So in which of the three cases, if we add the combination instead of the solo agent, maybe an SGLT2 inhibitor or maybe a DPP4 inhibitor, we will extract the maximum benefit. So if you see the first case where the HbA1c was 10 and the patient was already on an SGLT2 inhibitor, if we convert the solo SGLT2 inhibitor into the combination of SGLT2 and a DPP4 inhibitor, the question is whether we are going to get the benefit or not. The problem is at an HbA1c of 10 or more, when the patient is already on an SGLT2 inhibitor, the glucagon drive of the patient is so high that adding the combination with a DPP4 inhibitor will not suppress the glucagon drive. And maybe this patient might not be a particular patient where this combination will work the best. Okay, this combination can work in any of this patient, but the importance is here you have to, if you use this combination, you have to add insulin so that you can extract the benefit. Again, in the third case, where the patient presents with an HbA1c of 12, now what happens? Again, the same thing. You add this combination, but the glucagon drive in an HbA1c, high HbA1c is so high that the DPP4 inhibitor will not be able to suppress this glucagon drive. That's why there won't be characteristic decrease in the HbA1c. In both of these cases, insulin has to be there either or along with this combination. But in the second case, which I described, where HbA1c was 8.5 and patient was on a DPP4 inhibitor, this is the patient where if you convert the DPP4 inhibitor solo into the combination, here the patient is going to get the maximum response, because at an HbA1c of 8.5, the glucagon drive is not so high and the DPP4 inhibitor can override this glucagon drive, because we know that SGLT2 inhibitor will raise this. So there will be a curtailing effect. And finally, the HbA1c comes down, even if we do not add insulin in this combination, in the drug regimen. So these are the cases, and often and not, we will find such cases in our clinical practice where we will regularly encounter such cases, and if we use this combination in this group of patients, and I am sure this group of patient is the maximum as far as our regular diabetes clinical practice is concerned. And here, this combination always works wonder if used along with metformin and lifestyle combination. So this is the particular place where we can use this combination to extract the maximum benefit. We can use this combination in any of the patient who are uncontrolled, but to bring about decrease in HbA1c when the HbA1c is in the order of more than 9 or 10, we have to add insulin along with this combination to get maximum benefit. Thank you.